Welcome to Greenfield Community College's Survey of Health Careers. Today we're here with Leslie Kelly, faculty on the GCC Nursing Program, faculty in the GCC Nursing Program. Welcome.
Hi.
And we're going to be talking about your work at GCC, outside of GCC, and some other areas related to nursing.
Okay.
So first off, I'm wondering what originally drew you to nursing?
Well, I actually had gone to school and was a social worker before I went into nursing school. And I stopped that because as a 22-year-old person, I didn't know much about personal boundaries, and I burnt myself out really quickly in a couple of years working in Washington, D.C. So I did odds and ends of things. So I was a baker, I worked in landscaping, I did all of those things. But I like to help people, and I'm a question person. I like to ask the question why. And someone told me about an introduction session up at Vermont College, which has an associate degree nursing program. So that's how I ended up going back to school to get my nursing degree.
So you originally got your associate degree, or did you start with a bachelor's in nursing?
I started with an associate degree. Vermont College has a 2+2 program, or did at the time, and so you would roll into the bachelor's program after you finished your associate degree and had your RN license.
And did you immediately go on to graduate school, or did you work as a nurse first before you went on?
I worked as a nurse for about 6 years first. I worked in a hospital in southwestern Vermont, so over Bennington way, in the medical oncology unit. And from there, then I made a decision to go back to school to get my master's degree.
And what is your master's degree? What specialty do you have with your master's?
It's a master's in science and nursing, and I specialized in the family nurse practitioner track.
Mm-hmm. Okay.
Yeah.
What kind of continuing ed do you need to have to maintain your license as a nurse practitioner? And how does that compare to an RN license?
Okay. My understanding in Massachusetts, your RN license is renewed every 2 years, and you need 15 continuing education credit hours. Every state is a little bit different. Vermont is facility-based, so the facility actually determines the continuing education hours. As a nurse practitioner that's certified through the American Nurses Credentialing Center, and by the way, in order for me to practice with my license, I have to be certified by a national certifying body, and that's just one of them. So that certification process happens every 5 years, and in that 5 years I need to do 150 continuing education credit hours, and then in addition I either have to precept master's students, people going for their masters, or I can double those continuing education credit hours. So I have to do 300 hours in 5 years.
Wow.
Yeah.
I'm wondering how you balance your teaching along with your clinical practice.
It's been interesting. The school has been very supportive. So during the school academic year, I work at a physician's office just a half a day a week. So it's someone that I started working with. I've been there for over 11 years, and they've been very flexible. And then during semester break and summer break, then I pick up more hours there. So that's how that's worked.
And I understand that you're working on your doctorate in palliative care.
It's actually a postmaster's certificate.
Oh, okay.
So I'm not going for my doctorate.
Okay.
There's a lot of conversation about that.
Okay.
But this is additional coursework for a postmaster's certificate in palliative care. And when I'm done with this program, which will be the end of July, depending on how many clinical hours I have, I'll sit for another certification exam.
Mm-hmm. And how will that add to your nursing practice? What kinds of work will you use that certification for?
That's, I've been having a lot of fun with that in this semester, setting up clinical practicums. This semester I'm in 2 different long-term care facilities, and what's really exciting is I'm going to be able to use the nursing education piece a lot, because the type of individuals that are being cared for in long-term care facilities have a higher acuity than they have in years previous. So there's a whole staff competency piece that I'm going to be able to work on. So not only will I be seeing residents or individuals who are in a facility for rehabilitation from either, joint replacements or stroke, I'm also working with the staff to elevate competency levels.
And can you give us a general definition of what's involved in palliative care?
It's a new and emerging field. Palliative care has been around for a long time, but it's often described as being defined in 3 stages. So there's primary palliative care, which is when somebody's initially diagnosed with something like hypertension or diabetes, because it's going to be a lifelong practice for that individual to incorporate lifestyle modifications and exercise and those kinds of things. Then there's secondary palliative care, which really is when someone is starting to lose some of their functional level, and it's a place where you start talking about advanced care planning, like what does this person really want? What kinds of treatments and interventions? What kind of medications do they want to see themselves on long term? And then tertiary palliative care folds into hospice and end-of-life care.
Would you feel comfortable sharing an experience that you've had with a patient or a family that really touched you?
Let's see. I have a couple, but I was thinking about this a little bit. In one of my roles, probably 5 or 6 years ago, I was working with an early Head Start organization supporting their health services. And I ended up working with this family of a young child who had been born prematurely, had been in the hospital for 18 months after she was born, had a G-tube for feeding, and also had a tracheostomy because of just lack of development prior to being born. So this little girl was now 3 years old and wanted to participate in the preschool and the classroom. And because she had the trach, we had to secure health care personnel to ride on the bus with her in case the trach needed to be suctioned. So that was a whole big long thing to get worked out, but we got it worked out. And then by the time she was 5 years old, there were surgeries that they were looking at so that they could remove the trach. And this little girl loved to sing, even with the trach. Like, I even took a few times riding on the bus with her and got to know her really well. And she loved to sing. So there's a way for her to put her hand over the tube that's was in her throat that was helping her breathe, and she could sing, and she loved to do it. Well, I have to tell you now, I've seen this little girl. She's, 7, 8 years old now. She doesn't have a trach. She doesn't have a G-tube, and talks like all of us. So I guess what I liked about that is really working with this mom and this little girl, advocating for them to get the services and the treatments that they needed in order for this little girl to participate in preschool and eventually not have this tube in her throat. So that's one story.
Mm-hmm.
Yeah.
That's a happy story.
Yeah.
Yeah.
That's kind of why I.
Yeah. Well, I'm wondering what you see as some of the challenges in nursing.
I think what I'm going to say about that is the system that we have right now in healthcare. It's really not closing the gaps. Because, and a lot of it has to do with insurance and reimbursement issues. But nurses end up being caught in all of that because facilities are trying to figure out how to make things cost effective and still meet their bottom line. And individuals who go into nursing care about people and want people to get better and want to be able to help and support them. So what I see the biggest challenge is the time factor. Not really having the amount of time that you might want to spend with patients and families. And I think what I'd say is that's part of what started me moving along in my educational process, so that as a nurse practitioner, I actually do get to spend more time with patients and families. It's not all about filling out the documentation for the facility. So I think that's, that piece is changing, as well as people are sicker than they've been, and they're not kept in a hospital as long as they used to be. So there's a lot of education, patient and family education that needs to happen, and that's a huge role for nurses. But being able to do that effectively to make sure that families feel like they have the information they need to take care of their family member once they go home. So those two things. Yeah.
What kind of advice or words of wisdom would you give to students starting out, thinking about careers in nursing or starting out as a new nurse?
I'd say have an open mind about what your job might look like, because it's changing quickly. So if you're a person that wants to be able to help people and families, are good about connecting pieces like resource and referral kinds of things, so that's like more of a social worky kind of thing, but it actually is really useful as a nurse to be able to hook families and patients to resources. But the big thing is keeping an open mind about what your practice environment might look like, because it's not just about being in the hospital. There's a lot of there are a lot of roles that nurses have out in the community, sometimes in places you wouldn't even think to look in. I'm just trying to, long-term care is becoming, and another word we use is subacute care. So they're not sick enough to be in the hospital, but they're really not ready to go home yet. So people will be placed in what's called a step-down unit or a subacute unit. And I actually think that's a really fast-growing area in nursing. So
you talked about the 3 levels, the primary, secondary, and tertiary forms of palliative care. In your own practice, do you see a role for complementary or alternative medicine that you would incorporate in your nursing?
That's always going to be part of nursing, because meeting people where they are at the moment is the most important thing. So many people use herbs or have massage on a regular basis or do other body energy work modalities, acupuncture, Reiki, cranial sacral therapy. What I would say is that nurses need to be aware of those modalities, so that when people come to you and say, I do this on the side, then you can have the conversation about whether or not there's a potential interaction between that therapy and something that the allopathic physician or nurse practitioner might be prescribing. But that's the thing that I like about nursing. It's holistic. So even if you're not aware of all of the different herbs and what they do, or the homeopathic remedies, to at least have a beginning understanding, so that when people come to you, that's a possibility, or that you can offer. You know, people have trouble sleeping. You can say, have you ever thought about drinking some chamomile tea right before you go to bed? That's pretty innocuous. We give it to babies, but that could be considered complementary and alternative therapy. So, yeah.
So I'm wondering if anyone has questions in the audience. Sure.
Whenever you spoke of the 3 stages of the palliative care, I'm just curious that if you go into that as a specialty, do you pick one stage, or do you typically follow the patient through each stage?
Okay. What I would say is it would depend on the practice environment you're in. So right now I work in ambulatory care, so I'm more involved in that setting. I'm more involved in the primary and secondary part. But one of the practicums that I'm setting up for my summer session is hospice. So I'm probably going to be looking at the second and the third pieces. So some of it would be your own interest level, some of it would be the practice environment that you're in.
Like circumstantial, there's not like a set.
No, no. And if you do it as a specialty, you'll get the whole thing.
Okay.
Yeah, you get the whole thing. Yeah.
Other questions? Well,
Okay.
I'm interested in knowing, you talked a bit about how things have changed in terms of the patient being sent home much more quickly from the hospital over the past 10, 20, 30, 40 years probably. Other changes or trends that you've seen that have impacted nursing or that are important in terms of public health?
There's a whole shift with, there's actually a whole new discipline area of nursing informatics, which has to do with the computers and has to do with the software and databases that many healthcare facilities now are being encouraged to participate in. So what you're seeing now is individuals who've been nurses, practicing nurses for some length of time, now working in an informatics role so that they can help the staff nurses because they understand what nurses need, but then they also understand the software pieces that are important. All of the facilities that GCC currently has clinical rotations in for the acute care environment, the majority of the documentation is computerized, even the medication administration system. So that's no longer something that's going to happen, it's already happening. And as long-term care facilities get money from the government to upgrade and or even purchase systems, it's going to be part of those environments as well. I'm trying to think if there's, in terms of public health, I mean, this is more biological, but you know, bacteria and viruses constantly are changing and modifying, which means that areas of research for what's available in terms of medications to handle different bacterias. I'm not sure what people's understanding of is, but you hear something called MRSA, which is methicillin-resistant Staph aureus. There are forms of that bacteria. Staph aureus is a very common bacteria. We all have it on our skin. But now there are these forms, these versions of that bacteria that are resistant to many of the antibiotics that we have. And so there's a whole area of research going into that. Just trying to think if there are other pain assessment it's considered another vital sign at this point. So when people are having their blood pressure and their pulse and their temperature and all of that taken, a rating of pain management, comfort level is all part of that practice, and there's a lot of research. So evidence-based practice, I guess that leads me into most of nursing now has some foundation for what's called evidence-based practice, which didn't used to be. We used to just do things because we knew they worked or someone told us they worked. So if you happen to talk to any students from this program, they'll have a lot of stories where we tell them things we used to do as nurses that we no longer do anymore because there's no evidence to support the practice. So it's very funny to be in that place.
Yeah.
And actually, you mentioned something that we were just talking about in class the other day, which we were looking at a holistic view of medicine versus allopathic, and looking at the complementary nature of both. And I think you just said something that I think is really important for us to remember, which is that allopathic medicine as a standalone way of proceeding it requires that it has evidence to do what it does, which serves us in many ways. And complementary care, or what used to be called alternative care, doesn't necessarily have as much of that, although we were looking on the National Center for Alternative Medicine website the other day, and looking at some of the research studies that are posted there for the combination of both modalities, and also some of the research that's being done in the holistic modalities, like does chamomile do something?
Right.
Right. So it seems that research is really important.
Right. That particular agency has grown a lot in the last 10 years. So there are physicians who practice complementary and alternative medicine. And because of that, and because of their framework, there is more research, more and more research being done. Yeah. One of our students 3 years ago was a Reiki master and worked at Franklin Medical Center and was part of a study there doing Reiki for folks it was pain control primarily, but they did a whole study that got published. So, it's not that far away. Anybody can be involved in it if it's something you feel really passionate about. Yeah.
Yes. Carolyn?
Can you talk about the job outlook for nurses and LPNs and medical assistants?
Okay, I'm not going to be able to tell you much about medical assistants because I don't know. Medical assistants, I live in Vermont. I work in Massachusetts, but I live in Vermont. So we don't have as many medical assistants in Vermont. There's a couple of things that I'm going to say. I think there will always be jobs in nursing, but again, it's going to be LPNs and RNs, but it's going to be a matter of you looking into the environment. So if you're thinking you're only going to work in an acute care hospital, right now, you're not going to get a job there easily. What will change is there are nurses that are at retirement age that are really, really, really ready to retire. They are ready, they're done. But because of economics, they've put that off. But it's going to happen. So there's going to be a shift. So there is technically a nursing shortage. It doesn't mean you're going to find the job in the place that you think you want it. And the other thing is that New England is a really compressed geographical area. So if you don't have to stay in New England, you have more opportunities. So there's, that's another thing to think about, is that could you move away for a couple of years and get experience, and then move back to the area. Because your chances of getting employment once you have a little bit of experience goes way up than when you're a new grad. Did you have something more specific about LPNs that you were wanting to know about?
No, more about medical assistants.
Medical
They're
assistants?
Taking jobs from RNs because of the pay rate?
I'm sure in some practices that's true. They'll use a medical assistant in, like in large office practices. The individual that brings people in from the waiting room and does the initial intake, a lot of places are using medical assistants or LPNs to do those jobs rather than RNs because they're less expensive. Yeah. But that means there's jobs for RNs in other places. Okay? Yeah.
I just had kind of a general question. Like, you were talking about how much computers are coming into the nurse work field. It's not a requirement to take a basic computer class for your degree. Would you recommend it?
Some schools do recommend a entry-level computer class. I think that no matter where you end up working and whether or not you go into nursing, an introductory computer class makes a lot of sense.
Yeah, I mean, right now I know how to work the basics, but I'm wondering if that's enough, or, like I can type up a document and I can navigate the internet. So, should I,
You could learn things about databases if you did an introductory class, which might be useful. And it just reinforce what you know.
Yeah, okay, thank you.
Yeah.
Other questions? Well, thank you very much.
Thank you.
This was great.